Hello, I'm Debbie Dobbs, and welcome to my organizational assessment presentation of East Tennessee Children's Hospital. At the end of this presentation, you'll be able to identify the mission, vision, and organizational culture, summarize the organizational processes, describe the delivery models, delegation, and retention rates of nursing services, as well as list the human aspects of formal and informal leadership and employee motivation, identify the organizational theory of Children's Hospital, and explain the top priority for strategic change as identified through SWOT analysis. Children's Hospital is a 152-bed freestanding pediatric facility in East Tennessee in Knoxville. The mission is to improve the health of children through exceptional, comprehensive family-centered care, wellness, and education. The philosophy, as you can read here, is basically takes into consideration that children are special. They're not in miniature adults and require special training, equipment, and knowledge in order to care for them appropriately. Core values are respect, excellence, teamwork, integrity, and enthusiasm. This is a poster that is seen throughout the hospital in elevators, employee break rooms, the cafeteria, and different places with this poster has some specific behaviors underneath it. There are three parts of the organizational culture. One is service excellence, the second is family-centered care, and the third is quality, or otherwise known as Destination Zero. Service excellence is described in the employee handbook through this mnemonic of SHARE. Family-centered care is seen throughout the hospital. Family is allowed to stay with the patients 24/7 in all of the critical care areas as well as the inpatient floor. In March of 2017, the new perioperative center will open and families will be allowed to be with the patients in PACU as well. Their staff are expected to partner with families and include them in the decision making in their child's care. And there is a family advisory council made up of parents and family of previous and current patients at Children's Hospital. Everything that's done there is really run through the parent advisory council, and they give us insights on everything that we do, from policies and procedures to visitation, etc. The culture is the third one is Destination Zero, and you'll see these also throughout the hospital. Everyone makes a personal commitment to safety. Everyone is accountable for clear and complete communication. Everyone supports a questioning attitude. Organizational processes. This is the organizational chart of the hospital. You'll notice that the patients and families are on top, followed by the staff, then followed by the nursing directors or the directors of each department and the vice presidents, then the CEO and the board of directors. This signifies that the parents, patients, and families are at the top of everything that is presented for the hospital. Nursing shows shared governance. This is a graphic depicting the way that this works. The Coordinating Council is the decision-making body for nursing. All processes and improvements and procedures go through the Coordinating Council. Discussion or for conflict management is encouraged in a face-to-face. If it's not resolved, then it goes on to your supervisor, unless the conflict is with the supervisor, at which time it goes to the department director, then the department vice president, the vice president for HR, and then eventually the CEO. Capital budget is made up of three parts: the capital, the full FTE, and the operational. Capital is over $2,000. It's submitted by the frontline manager to the director, who looks at it. Then it goes to a budget team. There are several budget teams made up of experts, may come from all different departments. Some of them may include nursing, information systems, biomed, maintenance, really just depending on what the item is. They will prioritize all the budget requests and determine these, and then submit it to the budget committee, which is made up of the vice presidents in finance, who then look at the overall request of everyone The final decisions are made dependent on the total dollars available and then prioritization of each one. Full FTE, the frontline manager is given information such as the projected census for the following year, how many hours per patient day you have, the number of fixed and variable staffing. The frontline manager then prepares that budget, gives it to the director, who then submits it to the budget committee. Operational budget is your daily line items and your contracts, your minor equipment, your computers, food, printing, paper. It's submitted to your director in February. All budgets are reviewed by the budget committee. They present it to the board of directors in April. Then once that is approved, then in May it's presented to the department directors and managers, and then the fiscal year runs from July 1 through June the 30th. Quality management or quality improvement is a fairly good-sized department. It includes infection control, regulatory compliance, and quality improvement. They have a fairly good-sized staff, both clinical and non-clinical. The processes that they use include PDSA, Destination Zero, and Lean Process Improvement. Their responsibility includes submitting data to benchmarking and quality databases, regulatory audits. They have oversight and monitoring of the internal measurement databases. They track and analyze patient safety events. They are responsible for error prevention. This is their reporting structure. They start at the beginning with risk management, the QM department, information systems. It goes all the way up to the board of directors. Nursing services, the model really just varies according to the patient population. You'll see a modified team nursing in the inpatient floors, med-surg, about 70% RN, 30% non-licensed personnel. The non-licensed are what we call PCAs. You may know them as nursing assistants, and then HUCs. Total patient care is delivered with an all-RN staff in the PICU, the NICU, and hematology oncology, although the NICU also uses primary nursing for their micro-preemies and the babies with multiple comorbidities and long-term stays. RNs are responsible for directing the care of all the patients. They delegate to the non-licensed personnel. Most PCAs and HUCs are cross-trained and able to perform both positions. The health unit coordinators are responsible for doing orders, both paper and CPOE, as well as answering the call lights, the phones, keeping up with supplies of the department. PCAs do ADLs, vital signs. They transport, they ambulate patients on the unit. They basically do a lot of the first line care of the patients. Turnover at Children's was 11.5% in 2015. And then the national average, which is a little better than the national average of 11.7%. I was unable to obtain previous year's turnover. I asked and was not able to get it in time for this presentation. Turnover is measured as a full-time or part-time with authorized hours who terminate or go to PRN status. Human aspects. Formal leadership in the nursing department is, the top of course is the CNO. Underneath are 5 service line directors. As you can see them listed here. Under each of those service line directors, there's a nurse manager for each of the units. Each nurse manager has 2 assistant nurse managers, one of which is responsible for quality and safety, the other for time and attendance. The clinical leaders work on each shift each day. They are responsible for the day-to-day running of the unit. They do act as charge, they act as a clinical resource, they do the day-to-day running of the unit. All of these, the A&Ms, clinical leaders, and nurse managers are all in fixed staffing. Then you have informal leadership. They tend to be the one with the expert clinical knowledge. Also, it may be that those who have the most tenure in the hospital, they can either be a support or they can be a roadblock. It really just depends on the issue. Employee motivation. I got this from doing some staff interviews, and they pretty much were the same whoever I talked to, wherever I talked to. They really just believe in the hospital mission, that every child deserves to be cared for regardless of their ability to pay. I heard time and time again, we never know what kind of insurance they have, it doesn't matter. Quality care, doing the right thing, making sure the patients have what they need. They just love taking care of the patients and the families. And every one of them said, I want to make a difference. Organizational theory of Children's Hospital is, I believe, the resource dependency theory. It's described by Malatesta and Smith as organizations that require resources from their environment to help them be sustained financially. Children's Hospital has about 65 to 68% of their payer mix is made up of TennCare, which according to our CFO has the lowest reimbursement rate of all insurances, and that it is a major threat to the hospital's financial stability. We're a nonprofit. Hospital relies heavily on the community and corporate financial support. They're a member of the Children's Miracle Network, which you may not be aware of, but it's a fundraising throughout. It's a national organization. All the money given in an area goes directly to your local hospital. We have our own department dependent on fundraising. There's several fundraisers that are listed there, and their alliances with UT Medical Center and Vanderbilt to assist with helping with finance and support. The assessment, the strengths, I did actually 4 levels of staff. I did vice presidents, nursing department directors, nurse managers, and frontline staff. The strengths including a single pediatric facility. It's freestanding. The advertising that the hospital's niche in the market. There's commercials that are out that says we get kids. Community outreach, and just the variety of pediatric subspecialists. There was a little bit of difference in the weaknesses from staff and the leadership, and leadership was more concerned with TennCare numbers and percentages and the inability to get the main campus, and the frontline staff, as you would expect, would say nurse pay. Opportunities, it was the senior leadership said staff development into leadership roles, and the frontline staff said we need to make more alliances with other hospitals to increase our network because we can take care of such complex patients. Threats included from both sides said competition of other children's hospitals in the state. The top priority for strategic change, I believe, is to utilize our ability to care for complex pediatric patients to help reduce the threat of competition of other hospitals. And we can do this by the development of a comprehensive center for the care of pediatric spinal fusions. It can be done in 3 phases, the first of which is about to be implemented, and that is the development of a multidisciplinary care team, which has been done, and then develop and implement an evidence-based bundle for the prevention of surgical site infections following a spinal fusion. This is scheduled to be implemented in January of 2017. Phase 2 would be the development of an evidence-based care map for both idiopathic and neuromuscular spinal fusion, research and develop and implement the cost reduction strategies using lean methodology to increase profitability. The high-level budget is about $2,400 for that. And then phase 3 would be to develop and implement a marketing strategy to establish Children's as a comprehensive center for excellence for pediatric spinal fusions. This will be the biggest project and the highest. The high-level budget is about $250,000, and that is primarily based on marketing. But there's a lot of research, and then a return on investment would need to be done. We're beginning to start that in the stages. Thank you for your attention. This is a list of the references that I have used for this presentation. I hope you enjoy it, and have a nice day.